All right, so let's start with chapter 62. Let's go straight to the two fluid and electrolyte problems.
I'm sorry, what page is this?
What was that? What's the question?
I'm sorry, no, what page is this?
I'm on chapter 62, 1250.
Thank you.
All right. We haven't talked about diabetes insipidus, right? Or did we last week?
No.
No.
No? Okay. Alrighty, so let's begin with diabetes insipidus, and then we'll proceed with the two adrenal problems in the same chapter on Addison's disease and Cushing syndrome and Cushing's disease. So diabetes insipidus. So this is how come this is so familiar? Are you sure this wasn't in another semester?
Well, yeah, but we didn't talk about it.
No, I mean, did we cover this from another semester?
No. Third semester, I think.
No?
Nah.
Skipped it in my class.
Okay, so let's begin here. So there are two opposite problems here. We have diabetes insipidus and syndrome of inappropriate antidiuretic hormone. They are complete opposites. Both problems are caused by a antidiuretic hormone problem. In diabetes insipidus, first of all, this has nothing to do with diabetes. This is just the term, diabetes insipidus. But the main problem here is there is a lack of antidiuretic hormone. So it's either a deficiency, meaning your hypothalamus is unable to produce antidiuretic hormone, or the other problem is nephrogenic, which is the kidneys do not respond to the antidiuretic hormone that your body is secreting. So the main purpose of antidiuretic hormone is to reabsorb water. Now, unlike aldosterone, which affects both sodium and water, antidiuretic hormone only affects water. So the main problem here is no antidiuretic hormone. So are you able to reabsorb water?
No.
No, leading to polyuria. So the patient here is constantly diuresing. As a result, the patient has severe dehydration. So every single day, this patient can lose up between 4 liters or up to 30 liters of water. So the only way that's possible is the patient should keep up with the water loss. But as fast as they are drinking water, that's also as fast as they are losing it. So it's like the patient is a leaky bucket. So they take water in, it comes right out. But if they fail to replenish the water though, then they get into trouble. They could go into severe dehydration or possibly hypovolemic shock. Although antidiuretic hormone affects only water and not sodium, however, because of the dehydration here, because of hemoconcentration, it may indirectly affect sodium level through hemoconcentration though, not by, because the antidiuretic hormone won't cause the reabsorption of sodium, only water. So therefore, if you don't have it, you're losing water and the sodium level rises due to hemoconcentration, meaning when you draw blood from this very dehydrated patient, of course, the blood sample you're taking is a very concentrated blood sample. It doesn't really matter. We won't have to distinguish between primary, secondary, or nephrogenic diabetes insipidus. Those are just the causes, because the signs and symptoms, the patient's presentation is the same. And the interventions don't really make that much of a difference, except for, let's say, if the DI is caused by the drugs, then of course we will simply stop the drugs, but won't make a difference as far as the supportive interventions that we will be using until the condition resolves. Chart 62.5, this is nothing different from what you learned in chapter 11, except for two things under the urine. If you remember in chapter 11, a dehydrated patient, what will their urine look like? When you
It'll be dark.
all right, so
Concentrated.
right, so that was the presentation of a dehydrated patient in chapter 11, correct? So you're very dehydrated, so therefore your kidneys will go into oliguria, or a urine output of less than 400 ml. So therefore your urine, therefore your analysis will show a very high specific gravity and a very dilute urine. I mean, a very concentrated urine, right? Not so in diabetes insipidus. This patient is hypotensive and dehydrated in every respect. Look at the cardiovascular symptoms. Blood pressure is low, heart rate's high, pulses are weak, blood samples very concentrated. However, look at the kidney symptoms. There is instead increased urine output, and because the urine output's so high, it is very dilute. So this is the only odd presentation. In all other dehydrated patients, yes, they have decreased urine output, they have a very high specific gravity. This is the only exception. This one and syndrome of inappropriate antidiuretic hormone, these are the only two that break the rule. Okay, the general rule is you're dehydrated, your urine is supposed to look very concentrated, you're supposed to have decreased urine output. But in diabetes insipidus, you become dehydrated because you're making so much urine. And because you're making it so much in a little amount of time, the kidneys are unable to concentrate the urine, resulting in a very low specific gravity. But again, if you look at all the other symptoms, they all point towards decreased fluid volume, decreased perfusion, decreased fluid volume overall, decreased preload. I won't ask questions on the diagnostic test, only on signs and symptoms, and of course the resulting. That by diagnostic tests, I mean the water deprivation test that they do to diagnose the disorder. Look at the amount of urine this patient will be producing. So anywhere between 4 to up to 30 liters a day. So how do we help this patient? Obviously, they're losing so much water, so we replace it either by mouth. If they're still able, we give them lots of fluid. We try to encourage them to replace water equal to the amount of urine they have lost during the previous day, as much as possible. Okay, we have them estimate. Of course, it's not practical to measure your urine if you're out and about. Let's say you're out at the beach. You can't really realistically use the urinal to measure your urine output and then drink the equal amount of water. So they're just asked to estimate. In the hospital, there's no problem because we have intake and output measurements. But at home, these patients will just be asked to just keep drinking, and they are taught toward the discharge teaching part of the chapter is with medication therapy. They are asked to make adjustments to the drug dose so that they can increase it in times of increased urine output. They are taught that increased thirst and the polyuria are both signs of the need for an increased drug dose. The drug main drug used here is a synthetic form of antidiuretic hormone. It comes PO in a spray, and in the hospital, it can also be given IV. So here are the recommended doses. So as at home, they can take 2 to 3 doses daily of the spray. And here's the warning. In the hospital, the IV form is 10 times more potent or stronger than the PO or the nasal. Since the most accurate indicator of fluid volume is the weight, so we encourage the patient to weigh themselves daily, and keeping in mind that as you learned in chapter 11, every pound of weight lost or gained is equal to 500 milliliters, or every 1 kilogram gained or lost is equal to 1 liter of water. And here is what I mentioned about self-care. The patient needs to be aware that if they have polyuria and polydipsia, then that means they need another dose of the spray. Because they're drinking water like crazy, and sometimes it's hard to keep up with their intake, they are encouraged also to watch for the symptoms of overdoing it. Water toxicity can occur during day-to-day fluid replacements, and signs of water toxicity are the following. So they just still need to be aware. This is always the problem with endocrine disorders. The treatment for one may lead to overdoing it, meaning if you're treating dehydration, you could go into fluid overload, and vice versa. And that's about it. Any question on diabetes insipidus? Questions? Violent reactions? Alrighty then. Let's do the opposite. So we went from having not enough antidiuretic hormone to this time too much antidiuretic hormone. Causes vary. This is a common complication of stroke. So for exam 2, when we do chapter 45, SIADH will be tested again because this occurs frequently in stroke patients, and also in the same chapter, chapter 45, traumatic brain injury patients also may develop SIADH. The rationale is because of increased intracranial pressure. It tends to result in an overproduction of SIADH, which of course can have devastating effects on the stroke patient who is already having increased intracranial pressure. So if the patient goes into further fluid overload, then of course that will increase intracranial pressure some more. There are other non-CNS causes, mostly cancers and even pulmonary disorders.
It was one of the emergencies of the cancer, I remember.
I'm sorry, sir?
It was one of the cancer emergencies.
Right, this is one of the oncologic emergencies. Very good. So we had 6 oncologic emergencies. This was one of them. Just like diabetes insipidus, this can also be triggered by medications. And here are some. These 2 were mentioned in chapter 22 as well. These are used for chemotherapy. And they, of course, are the reason why certain cancers can lead to SIADH. So not only the drug, but the cancers themselves will either primary or secondary tumors of the brain. So here, for instance, lymphoma, it could be a secondary tumor growing in the brain. Same thing for lung cancer. So this is the complete opposite of diabetes insipidus, wherein you had dehydration there. This one, You have too much antidiuretic hormone, so now your patient doesn't have polyuria. Instead, the patient has oliguria. But this is the same hormone we're talking about, the antidiuretic hormone, which again only affects water. However, just like in diabetes insipidus, wherein if the patient gets very dehydrated and therefore the blood becomes very concentrated, this one's the opposite. The patient keeps reabsorbing water. So therefore the patient's blood volume increases, resulting in hemodilution this time. And just like in diabetes insipidus, the sodium level here in DI increased. This time it will now decrease. And under signs and symptoms, though, it may be rational to think that the patient has fluid overload, that you will see edema. Not so in SIADH. If you read the statement here, because SIADH only affects water and not sodium directly, let me emphasize directly, okay? Meaning because antidiuretic hormone only causes the reabsorption of water. Salt is not reabsorbed. So in fact, the sodium level is low in SIADH. So typically you don't see dependent edema here. However, since the patient in SIADH may develop heart failure because of the increased preload, then you will see dependent edema. But this dependent edema is not from SIADH. It is now resulting from heart failure, which is a complication of SIADH. I hope that makes sense. These are already mentioned in the table. Table 62-1 for the causes. Let's go now to signs and symptoms. Now for this exam, I will not go to chapter 11 as far as testing you on the signs and symptoms of hyponatremia because it is quite severe in SIADH. The sodium level here can go as low as 115 or even less. So for the exam, I will only use the signs and symptoms listed in chapter 62. There is no chart for the signs and symptoms, so you are limited to what's on the paragraph. But since this is a patient in fluid overload, so just look at the chart listing the key features in diabetes insipidus and then do the exact opposite. You can never go wrong. So instead of hypotension, you'll have hypertension. Instead of weak pulses, you have increased strong bounding pulses. You'll have jugular vein distension, etc. Let's go now to interventions. So this patient has so much antidiuretic hormone. So therefore, does this patient need water like a diabetes insipidus patient? No. Instead of giving water, we will now restrict this patient's fluid intake. The restriction will depend on how much urine were they able to produce yesterday. So that means we can only encourage them to replace what their body is able to get rid of. So if the kidneys made 400 ml yesterday, then their fluid intake must start at fluid 400 ml today and a few more though, because we know that we do lose water by other means, not just through the urine. We do lose water from breathing, talking, from the feces, from perspiration, okay, from saliva, for instance. Okay, so we add an additional amount, anywhere between 600 to as high as 900 ml for insensible fluid loss. But typically the number is around 600. And typical fluid restriction is around 1,000. So that will account for the oliguria and the insensible fluid loss, which is 600. make sure you do accurate intake and output. And like in DI, we weigh this patient daily, and the same thing equivalence for the weight gain or loss. So 1 kilogram, 1 liter, 1 pound, 500 milliliters. Drug therapy. If we gave vasopressin or desmopressin and DI, of course, that's not indicated here. Tolvaptan, there are two Vaptan drugs here, tolvaptan and conivaptan, are used only for severe hyponatremia, because the problem with correcting sodium here is, although we have a choice of using, let's say, hypertonic saline, which is 3% saline, that can be dangerous because it's a hypertonic solution. Of course, yes, sodium levels will be restored to normal. However, since it's a hypertonic solution, what will happen to blood volume when you administer it?
It will go down.
By osmosis. So if you put a hypertonic solution in the bloodstream intravenously, where will fluid shifting go according to osmosis?
Oh no, inside the vascular space.
Okay, so it will increase blood volume. So is that good in a patient with SIADH?
No.
No, that can be dangerous. It will actually exacerbate the fluid overload. So that is preserved only if the patient gets better. But until then, though, they try to avoid that. So we will stick with, again, we also reserve the Vaptans for severe hyponatremia because they have also a very serious side effect. They can lead to hypernatremia. Okay, that's why the reason also it's never given outpatient, certainly not at home. It can only be given in a supervised setting, like a hospital or a nursing home. Okay. Diuretics is an option to decrease the fluid volume. However, you know, diuretics will also cause further sodium loss. Although even you say loop diuretics or thiazide diuretics mostly affect potassium. However, if you read the drug book, it does also contribute to sodium loss to a certain extent. I already mentioned the hypertonic saline, and the sodium levels drop to dangerous levels here, so that the patient, if you remember in chapter 11, this will cause neuro changes here. Low sodium level will cause the brain cells to swell, that will therefore lead to cerebral edema, increasing intracranial pressure, therefore making the patient at risk for seizures. So your interventions here is to institute seizure precautions. Now, I'm aware that you already covered seizures last semester, so I will include seizure precaution questions here. What are they? When a doctor orders seizure precautions, what does the nurse prepare?
You lift the side rails of the bed and pad them.
All right, that's one. Padding the side rails. What else?
Turn them on their side.
Right.
Can you speak louder, please? I didn't get the...
Suction equipment.
Okay, oxygen and suction equipment. What else?
Turn them on their side.
All right, aspiration precautions. Do we still do padded tongue blades?
No. Nothing.
No.
No.
All right, nothing in the mouth. And what should each patient have when they're on seizure precautions? What must be inserted into the patient? Status.
IV.
All right, make sure your patient has an IV access. It's impossible to put one during a seizure. It's too late. They're seizing, muscles are contracting. It's impossible to insert a needle safely, at least. I already mentioned heart failure could result in this condition. So that would be left-sided heart failure manifested by pulmonary edema. And that's it. Questions? You just had a quiz, so technically you can go on, right? Let's finish adrenal disorders and then I'll give you a break. See, no violent reactions. Alrighty then, let's proceed. So we leave the hypothalamus. They go now to the adrenal glands. So we have two sitting on top of each kidney. These wonderful glands produce three hormones. They are responsible for producing salt, sugar, and sex hormones. As far as the sex hormones go, it's only true for the females because the sex hormones in the male is in the testicles. So the salt hormone here is aldosterone. The sugar hormone is cortisol, which is a glucocorticoid. So we have mineralocorticoids and glucocorticoids. Let's review. Aldosterone does what?
Promotes retention of volume.
Okay, so it causes sodium and water retention. Very good. It is, of course, an emergency hormone. What about the glucocorticoid, the cortisol? What is it responsible for?
The stress hormone.
Okay, so it is responsible whenever you have stress, and by stress we mean physical, emotional stress. That's why our uniforms, if you are still wearing your uniforms, they've shrunk, right? From when you had your NUR 100 course to now 205. These are poor quality scrubs. They shrink over time, right? Because the nursing school is very stressful. So it causes our uniforms to shrink. You know what I'm talking about when I say that, right? Okay.
No, Professor, we don't.
Yes, too many snacks.
Well, I don't want to say it because it makes sense to
I did.
I've heard. Anyway, so these are important day-to-day hormones keeping us alive. So when we are exposed to, especially nurses, so you'll be busy at work, you'll be lucky to get a bathroom break or a lunch break. Okay, so you're gonna have to eat on the go. I don't mean to discourage you. I mean, it doesn't happen every day, but there will be days like that wherein you never thought how much urine your bladder could hold, or how long you last without food or water. So what's keeping you alive are these two wonderful hormones. So we have aldosterone and cortisol. Of course, they have side effects if they are increased in constantly every day. So it will have consequences. So let's start with adrenal insufficiency first. So if you have a deficiency of these two hormones resulting from adrenal insufficiency, so what will the patient look like? I'd rather not really focus on the androgen level, even though I'm not saying they're not important. Let me just say they're not life-threatening. They do still pose a significant impact on the female because this is affecting how they look. Look at the effects of low androgen levels. You'll have decreased hair. And by hair, I'm not just talking about pubic or axillary hair here. It will also affect the head. I mean, we're worried about losing hair in hidden areas because you try to get rid of them anyway. But the ones that determine who you are, you know, you giving your identity, the hair on your head, is affected here, sadly. And on top of a few other things, which we'll talk about. But let's just cover the life-threatening part. Before we go to the day-to-day symptoms and management here, there is a crisis which is life-threatening that could occur. And we need to cover this because the trigger is quite common. Look at the trigger. It simply says a stressful event. Now, what is a stressful event besides surgery, trauma, and severe infection? It actually varies, right? Because our perception of stress varies from individual. So for me, for instance, to say, Miss Sharma, okay, I tell Miss Sharma that, Miss Sharma, since we are now on lockdown, I can no longer, go out with you. I can't see you anymore. So I can only imagine how that would affect Miss Sharma. She's probably saying now, I don't care. Let's say, what about Mr. Rodriguez? If I told Mr. Rodriguez, hey, Luis, I can't go out with you anymore. Right? See, he's even speechless. Okay, so that's how it's okay. I'm only kidding. I still, we're still good. So that is a stressful event nonetheless, even though the patient didn't have surgery, trauma, or severe infection. So a crisis can be triggered. So imagine the effects of the day-to-day symptoms here on steroids now. So you exaggerate the resulting symptoms. So let's begin with what is the effect of low aldosterone. So Maria said earlier, aldosterone is responsible for maintaining blood pressure. So sodium and water absorption. If you don't have that, what happens to your blood pressure?
It's going to drop.
Okay, so one is severe hypotension. Is that life-threatening?
Absolutely.
All right. So now let's go to cortisol. And you said also cortisol is responsible for blood sugar maintenance. So in times of starvation, so we need cortisol. This is a stress hormone keeping you alive during emergencies. Even if you're not eating, you don't fall down. Okay, so you stay up, your sugar stays normal, even high, because of cortisol. So therefore, if you lack cortisol, what happens to your sugar levels? You have very low cortisol levels.
Will drop.
It will drop. So hypoglycemia, is that an emergency?
Yes.
Yes. And then indirectly here, as a result of low sodium and low fluid volume, because you have low aldosterone, what will be the high electrolyte? So if sodium drops, what will rise?
Potassium.
Potassium will rise. Hyperkalemia, is that life-threatening?
Yes.
All right, so that now covers our best practice here because these are the three life-threatening conditions all happening at the same time. So if a patient who has adrenal insufficiency or Addison's disease, who has low aldosterone, low cortisol levels, will experience shock, hyperkalemia, and hypoglycemia. Each one by their own are life-threatening. So if you ask me which one's a priority, I don't even know where to begin because all three can kill the patient. So the answer would be we take care of them at the same time. So first is hormone replacement. We give them fluids, normal saline or 5% dextrose. And this would be rapid, okay? So we're talking about bolus infusions here. On top of that, that's not going to cut it. We have to give aldosterone. So we give a glucocorticoid, hydrocortisones or Solucortef. We give a bolus and then a continuous infusion constantly over 8 hours. And then every 12 hours, another 2 doses of 50 milligrams of the same hydrocortisone. Because the patient here is under stress, so we already give H2 receptor blocker here prophylactically so the patient doesn't develop stress hormones. Because remember, the trigger here is severe, where was it? A stressful event. Okay, again, these are the stressful events commonly. So you got sick, either physically or emotionally. Now here comes hyperkalemia. This was extensively discussed in chapter 11. There are several ways to lower potassium. You either shift potassium. Another way to, besides insulin, regular insulin IV with dextrose, by the way, they have to be given together, okay? Don't answer insulin only or dextrose only. They have to be given together. The other option is calcium gluconate, has the same effect. KX-late, or this is sodium potassium sulfonate. However, this is not your priority because of course this thing here takes 2 hours to work. This one takes about maybe 20 to 30 minutes. It will already start to lower potassium. But between the two though, this one here shifts potassium. So technically after the insulin wears off, potassium levels rise again because this one will only transfer the potassium into the cell. This one will eliminate potassium, but again takes too long to work, takes 2 hours or sometimes longer before the patient has a bowel movement. This is an option to loop and thiazide. However, what else do you lose besides potassium?
Water.
Water, and we don't want, right now we don't want to lose water though because our blood pressure is low. In fact, we're giving fluid boluses, so this would be your first choice. So we would still go with this to shift it, drop it rapidly, and until this guy here kicks in. Of course, we will do potassium restriction. So this is a no more spironolactone. If you put it in order though, we would still go with cardiac monitoring because even though this one will lower, it doesn't lower it fast enough. It still takes 20 to 30 minutes to drop, to shift. So therefore, this would be the safest intervention here so that you will identify whether or not the patient's already in cardiac arrest. Right now, you won't be tested on this because we haven't done chapter 34 yet on dysrhythmias. But later for exam 3, I will come back to hypokalemia. So you are now tested on potassium effects on, potassium imbalances effects on your EKG. And finally, hypoglycemia, which we just concluded last week. We give either glucagon, IV dextrose, 50% dextrose. Well, this patient's already unconscious, so there's no option here to give food. Imagine you have all three. You have shock, you have hypoglycemia, and hyperkalemia. So this patient is not conscious. So we finished the emergency management. Let's go now to the day-to-day dealings. So the patient will still have hypotension, hyperkalemia, and hypoglycemia. I mean, they're at risk for these every day. However, we can maintain this, okay, as long as they don't have the really stressful event, which will trigger a crisis, namely infection, trauma, or surgery. These are the causes of adrenal insufficiency. Primary causes and secondary causes. Now, we can treat primary causes. Okay, it's easy. Well, I shouldn't say that because autoimmune disorders have no cure. So I shouldn't say that. But at least tuberculosis is manageable. To some extent, cancer can be treated. AIDS though, you can just maintain it, but you can at least control if it's a primary cause. However, secondaries, not that easy because can you stop treatment for, let's say this one? Can you necessarily avoid it? Not really. And one thing though, in let's say whenever you've heard it from either from concepts to fundamentals of nursing to pharmacology, remember when we teach patients never to stop their steroids abruptly? You remember that?
Yes.
Yeah, what was the rationale for that? Why should you taper steroids? Why can't you just stop it right away?
You hear the rebound effect?
Not really. Look at this. What will it cause if you stop steroid?
Adrenal insufficiency.
Okay, it can actually trigger an adrenal crisis. This will occur. So that's the rationale why we don't stop steroids right away. Signs and symptoms similar to what the emergency chart already showed, but this one will be at a manageable level. Others unrelated are there will be an increase in your melanocyte stimulating hormone, resulting in this increased pigmentation right here. These are the other key features. So this one obviously are signs of the electrolyte imbalances, so muscle weakness from the hyperkalemia, because whether your potassium's high or low, they manifest the same way. There is muscle weakness. GI, these are your symptoms. And skin, we have the hyperpigmentation, and of course in cardiovascular, which we already extensively discussed on the emergency best practice chart. So we have hypotension, hyponatremia, hyperkalemia. For hypocalcemia, this just goes with potassium. They tend to go together all the time. So if potassium's high, so is calcium, and vice versa. Interventions we already did. However, instead of the emergency, there's no need for the boluses because of course the patient's hypotension here is not that low. Okay, so we were mostly controlling it with the hormones. So the patient is just given daily doses of hormone replacements using glucocorticoids and mineralocorticoids on a daily basis. So that will be on chart 62-9, which is after this chart. These are the diagnostic testing. So we'll come back to this later when we get to Cushing's disease, Cushing syndrome, because this is the opposite right here. So right now we're on Addison's disease, so column number 3. So we already discussed it. Your salt, sugar, and sex hormones are low. So aldosterone's low, sodium's low, potassium's high. Glucose, your sugar level, your cortisol is low. So your sugar will also be low, or although it can be normal in Addison's. Then, as I already said, calcium will be going in the same direction as potassium. And yeah, because you're dehydrated or hypotensive, so less perfusion to the kidneys, this will be increased because there will be some kidney injury. Cortisol definitely low, that's why your sugar is low. We'll come back to the 4th column when we go to Cushing's disease. This test is another thing I'm not testing. I won't ask you this because the doctors are the ones doing that, so we don't need to interpret it. Interventions now. So the same as already on the chart, but on a day-to-day basis. So we're just maintaining because we're not necessarily dealing with an emergency every day, although we watch for it because anything, again, stressful events are relative. So anytime this patient may experience a stressful event, it could trigger a crisis. Here's chart 62-9. These are the drugs. The instructions on how to give the drugs are later in chart 62-11. So let's just start with this chart first. So these are the drugs they take on a day-to-day basis. So we have cortisone, hydrocortisone, or they can be on prednisone or fludrocortisone. So here, this is a drug chart. So the testable part is always the nursing implications. Yeah, any steroid you should take with meals, right? So, and also any steroids, remember these are taken forever because there's no cure for Addison's disease. So you tend to have the opposite effect, meaning you may end up getting too much of the hormone, resulting in Cushing syndrome. Steroids cause water retention, so you have rapid weight gain, and that water retention, on top of that, it also causes hyperglycemia. To help you with this, there's actually a chart in chapter 17, which is complete. Please read chart 17-2. I think it's page 130. Let me guess. No, it's not. So chart 17-2 is under the organ rejection chapter.
Page 302.
Oh, 302. Thank you. All right, so here's the chart. 17-2. So the first one here, these are the steroids. So the complete, because remember, these patients are taking these forever. So this will be your complete complications here, because they may end up with taking too much. However, when these occur, of course, you simply talk with your physician and they will adjust the dosing. But this is easier said than done. It's not really that easy, especially when you already develop the Cushing syndrome, which is pretty much all of these here together. So a patient with Cushing syndrome has all these problems. Okay, so the fluid retention here, as shown in chart 17-2, causes the hypertension, which is seen in Cushing syndrome. So this is what I mean by you're treating Addison's, you may develop the other problem, which is now Cushing syndrome, which we'll talk about next. On top of this, because it is a stress hormone, so your stress levels will be high, obviously, so your sugar's high. That will lead to hyperglycemia, and the body automatically, especially the liver, will automatically turn any excess sugar into fat. And that fat can either go to your belly or elsewhere in the body and also in your blood vessels. So it may cause hyperlipidemia and then atherosclerosis. Going back to the stress hormone, because it's a stress hormone, so it increases gastric acid production, causing GI ulcers and then bleeding eventually. And once your acid levels are high, it will decrease calcium absorption in the GI tract, causing osteoporosis. And this fluid retention not only causes your hypertension, but also could cause fluid retention in the eyeball, which you guys already talked about in the previous semester, glaucoma. So it's not, it's not a happy disease to So either you have Addison's, you can end up having Cushing's when we start treating it, and it gets worse from there as we talk about the next interventions or the next disorder. Please read this highlighted section, or even if I didn't highlight it, it's italicized. That means it's a very testable material. So this just says about salt restriction or diuretic therapy should not be started, because again, you may trigger a crisis when doing that. Any question on Addison's disease before I proceed with Cushing's? Are you guys awake?
Yes. Yes.
All right.
Yes, sir.
Yesterday during my class, somebody's actually was snoring and they didn't mute their microphone. So the whole time we had class, we had the background snoring music, which was, which was nice, made it interesting. Cushing's disease. So this is now the opposite of Addison's. This time you have high level of salt, sugar, and salt hormones. So we kind of already discussed what the patient looks like because they were exactly the effects of taking too much steroids. So this is now what your patient looks like. So here you have your truncal obesity. We didn't take this patient's blood pressure, but we can assume this patient has high blood pressure. And this patient has high aldosterone, so the sodium is high and potassium is low. Patient's blood sugar will be high. And because of the increased deposits of adipose tissue here, it will stretch the skin, thinning it. You can't see it, but clearly on this picture, but see this stretch mark here. So you'll have striae all over the abdomen. You have the buffalo hump. You have the facial edema, because there will be pretty much anasarca. There will be edema everywhere.
Moon face.
Water retention, right? The moon face. There's no hair, right? That's probably the only good thing that comes here. However, this can, as long as it's Cushing syndrome, I'll show you the difference between the two earlier. Cushing syndrome can reverse this. Okay, we can adjust the medication. And the treatment actually, if it's Cushing's disease, we can treat Cushing's disease, meaning you can reverse all this. However, if you decide to treat Cushing's disease, the treatment is adrenalectomy, meaning we'll remove one or both adrenal glands, meaning you went from high salt, sugar, and salt hormones to now no salt, sugar, and sex hormones. So therefore, what will you develop when we treat Cushing's disease?
Adrenal crisis.
Addison's disease. Well, hopefully not adrenal Addison's crisis, but although it's potential, because remember, this patient will undergo surgery, and during surgery, they develop adrenal insufficiency, meaning when you treat Cushing's disease, now they become Addison's disease. And this all happens during surgery.
Sounds like a catch-22.
Exactly, yeah. So this is the very interesting part here. So we have either Cushing's disease or Cushing syndrome. If it's Cushing's disease, these are the causes. It's a pituitary or an adrenal problem. The problem is usually a tumor. So you have adenoma, pituitary adenoma. So there's a tumor growing on the pituitary gland. And then we have cancers, which are the rarer causes of Cushing's disease. Or you have adenomas again, this time on the adrenal gland. Cushing syndrome is treatment for Addison's disease. or treatment for these other conditions. Meaning every person who's taking steroids for a long period of time can develop Cushing syndrome. Again, the main difference here is Cushing's disease. This one we can cure this. The problem is the cure. The patient, after we cure it, the patient becomes Addison's. However, in Cushing syndrome, there's really no way out of this, because remember, when this patient here decides to treat Cushing's disease, and then now they're in Addison's, right? So according to chart 62-9, if you have Addison's disease, you have to take the hormones. So what ends up happening? What's another possibility? So you go from Cushing's disease to now Cushing syndrome. So round and round we go. Because we really can't stop steroid treatment for these. I mean, asthma patients, you're being asked to choose, do you want to breathe or do you want to look good? Right? You can't really choose. Asthma patients have to, or COPD patients have to take steroids. Autoimmune disorders, Crohn's, psoriasis, ulcerative colitis, rheumatoid arthritis, okay, or organ transplants. Because if you don't take steroids, then you lose the organ. Chemotherapy, same thing. Or allergies, take steroids also. Or chronic fibrosis or other chronic inflammatory diseases. Signs and symptoms, we already looked at the patient and we discussed it using chart 17-2. Here are your other symptoms. So the moon phase, we discussed already, the hypertension. The bruising and the petechia here is due to the overstretching of the skin. So patients prone to skin tears, skin injury, bleeding. And because they have hypercalcemia here, hypocalcemia, because there is hypokalemia, there will be muscle wasting because now you have mostly fat, so therefore less muscle mass. And that weakens you, right? The muscles weaken, you'll be prone to falls, plus you have osteoporosis because of the hypocalcemia. So when you do fall, you could fracture. Skin, these patients should be handled carefully because they can easily sustain tears. And on top of that, because they have high steroid levels, high cortisol levels, so they're at risk for infections. At this point, you'll see redundancy here in the paragraphs. So this one section right here, you can read it again, but it's really the same thing, which is in chart 62-10, but go ahead and read it again. Psychosocial, though, we didn't talk about yet. So these patients will have emotional instability. So mood swings, going from one end of the emotion to the other extreme end. Lab results. So let's go back to the, what page is this? 1257. Let's go back to the chart where we compared both earlier under Addison's. Right here. So chart 62-8. So here's the opposite. With Cushing's disease or syndrome, sodium is now high, potassium is low, calcium low, glucose mostly increased rather than normal. Bicarbonate this time is decreased, and BUN can be normal, but definitely cortisol is high. What page was that? 1257. Let's go to interventions. So the goal is to restore normal or at least acceptable body appearance. Again, for Cushing's disease, that's an easy fix because we do surgery. There you go. However, you do develop Addisons, which now require hormone replacement. So you go from Cushing's disease to technically you may potentially develop Cushing syndrome because of Addison's disease. So treatment is related to the symptoms. So blood pressure, you give these patients blood pressure medications. Let's do non-surgical first. So it's all about symptomatic. So they're at risk for falls, institute falls. They have increased blood pressure and fluid volume. So watch for pulmonary edema from heart failure. Protect the skin. Now, drug therapy, I won't test because can you read this for me, Miss Julie?
Where do I start?
Right here.
Drug therapy involves the use of drugs that interferes with adrenocorticotropic hormones, ACTH production, or adrenal hormone synthesis for temporary relief.
Okay, what's the key word there? How long is the drug therapy gonna last?
Temporarily.
All right, so let's not even talk about this because the temporary relief here is, I mean, a few months. The patient will have to opt for surgery. So let's go to surgical intervention. The rest of this here, please read nutrition therapy. These are all non-surgical, non-pharmacologic therapy. So of course they have high sodium already, so no added salt. Some fluid restriction may be, may be instituted. The same thing, because fluid overload must be monitored, so weigh daily. So here's surgery. Now remember, before surgery, these patients have been having high salt, sugar, and sex hormones, correct? So what will happen when you, because the causes were either in the case of Cushing's disease, the problem was an adenoma on the pituitary gland or adenoma of the adrenal gland, correct? So when we do surgery, is it stressful?
Yes.
Could it trigger an Addison's crisis, Addisonian crisis? Because that's what they'll end up once we take out either the pituitary or the adrenal glands.
Yes.
Yes, okay. So to prepare these patients for that, let's do pre-op. What do we do? Because of that danger, because all those three, again, are life-threatening. So we have hyperkalemia, hypoglycemia, and hypotension, severe hypotension. So how do we avoid those three? What will be given before surgery, Miss Martin?
Glucocorticoid preparations are given before surgery. The patient continues to receive glucocorticoids during surgery to prevent adrenal crisis because the removal of the tumor results in a sudden drop of cortisol levels. Before surgery, discuss the needs for long-term drug therapy.
Very good, because after surgery, once the surgery stops, what will this patient be taking now? Miss Laura, Miss McPhillips?
Unilateral.
No, after surgery, what will be given to the patient?
Repeat it again.
Because now after surgery, what do they have? Do they still have Cushing's disease?
I'm not sure.
Lifelong glucocorticoids.
Okay, so we'll have to replace the hormones right after surgery. In fact, we start giving it before, during, and definitely forever after surgery. Skip this part because the information is mentioned here, and then unfortunately I'll have to go back to the beginning of the chapter because this is just how they arrange the information. But let's finish post-op care. Because this patient is at risk for acute adrenal crisis, so you watch for those. Definitely you watch hypotension, hypoglycemia, and hyperkalemia. However, in the case of adrenalectomy, in pituitary removal, which is called hypophyseectomy surgery, because how big is your pituitary gland?
Like half of a pea size.
Okay, it's a pea-sized gland. So which is typically bigger, adenoma or the pituitary gland?
The adrenal gland is bigger. Is that what you're asking?
Between the pituitary gland and the adenoma that's growing on the pituitary gland, which is bound to be bigger?
Adenoma.
Most likely the tumor.
Right. So can you save the pituitary gland? Can you possibly resect the adenoma around it and then preserve the the pituitary gland?
I'm sure they'll try.
It's difficult, no.
Possible. Okay, so it's all over the pituitary gland already. So of course you'll replace all hormones. However, in the case of the adrenal glands, the adenoma may only occur on one, not both adrenal glands. So that's why if you read this paragraph right here, how long will be the hormone replacement? Thank you for reading, Mr. Can you help me pronounce your name, sir? I emailed you and you didn't respond to me. Ikon.
After a bilateral adrenalectomy, patients require lifelong glucocorticoid and mineralocorticoid replacement, starting immediately after surgery. In unilateral adrenalectomy, hormone replacement continues until remaining adrenal glands increases hormone. This therapy may be needed for up to 2 years after surgery.
Okay, so if it's both adrenal glands, it's lifelong. However, if it's only one adrenal gland removed, the replacement may only be up to 2 years and you'll be back to normal. So you don't have to have Addison's disease all the time. Okay, if only one adrenal gland is removed. All right, so we took care of adrenal surgery. Now let's go to hypophyseectomy. Let's go back up and we'll come back to page 1259. Hypophyseectomy is up here somewhere. Right here. Chart 62-3, page 1249. So there are two possible approaches here. Rarely done is a open craniotomy, meaning they'll drill a hole, crack your skull open and then remove the pituitary gland that way, or the adenoma going on it. Or
They go through the nostril.
yeah, they can do it, what's the name? Transphenoidal hypophyseectomy. You can look up the procedures on YouTube. I won't show it to you. Anyway, or if it's transphenoidal, they go through the nose. And there's also another variation of that surgery wherein they'll have to make an incision at the roof of your mouth. But regardless, whether you do it minimally invasive route or you do open craniotomy, the patient still underwent brain surgery. So post-op, you, just like any other brain surgery patient, you perform neurochecks. And what is this? What are you looking for here? Which was, we talked about this again earlier this evening.
That's cerebral edema?
No, the output with intake. What's the patient developing post-op? Mr. Basam? Output greater than intake.
I'm sorry, I can't hear you.
Urine output is greater than fluid intake. So what is the patient developing?
Hypovolemia?
Remember we talked about this at the start. This was the first topic tonight.
Is it DI?
All right, so
Yeah.
the patient may develop diabetes insipidus, so watch for that.
Yeah,
And
okay.
it's a no-brainer. You had brain surgery, so we don't want to increase intracranial pressure. So any condition that requires the patient to take a deep breath and hold it, such as deep breathing, not deep breathing, but coughing, blowing their nose, or sneezing. Those activities mean you have to take in a deep breath, hold it, and then cough, blow your nose, or sneeze, right? The same thing also with bending at the waist. You can't bend at the waist without doing the same thing. You have to hold your breath, take in a deep breath, hold it, and bend down. The same thing also for sexual intercourse. You have to hold your breath and do whatever, right? So these activities involve that same activity, meaning, let's say giving birth to a big turd, the same thing. Pushing Valsalva maneuver is still going to cause you to hold your breath and, take in a deep breath, hold it, and then push. So all of these increase intrathoracic pressure. So therefore, the lungs will inflate and hold it, thereby squeezing the heart in the mediastinum. Therefore, when you squeeze the heart, you're squeezing the superior vena cava at the same time. So now venous drainage from the head decreases, causing increased intracranial pressure. I mentioned the incision at the roof of the mouth. That's why they prohibit brushing your teeth. Until then, you can use dental floss or mild oral rinses. And then, because if you went to the transsphenoidal approach, there will be a mustache pad or a nasal drip pad. So the patient will have to breathe through their mouth. So for a few days, this will be on there. Here's the avoidance of straining. And again, because the pituitary gland is removed, so all the hormones produced by the pituitary gland will have to be replaced for life. Questions about post-op care? Okay, let's go back to 1259. So we did adrenalectomy and hypophyseectomy. So this is the part wherein it becomes redundant. This sounds familiar, right? We already read this. I don't know why the author keeps repeating it, but it is redundant. Some though are not, like say this one, although we talked about it earlier, but here is the prevention of your GI ulcers, therefore preventing GI bleeding. These are the drugs to control increased acid, because the patient does have high gastric acid secretion. Okay, so this is for both Cushing's disease and Cushing syndrome. Because their steroid hormones are high, so they're at risk for infection. So institute neutropenic precautions. We already discussed these in chapter 40, both in third semester and again last semester, I'm sure, when you talked about chapter 40 in 201. And preventing acute adrenal insufficiency, you should know this already. We started with this earlier. And there's one more chart here, and then that should be it. So 6211 is similar to 62-9. 62-9 enumerated the hormone therapy replacement. This one is a continuation. They just went into more detail here because this is for how long are we doing the replacement therapy, especially if it's hypophyseectomy or bilateral adrenalectomy?
Lifelong.
For life.
Lifelong. So the patient must be aware of the consequences of taking it. So if they're having to take the hormones twice a day, make sure the second dose is not taken late at night. What will happen if you take it at bedtime? These are steroids and glucocorticoids. So will you be able to sleep? No. So you'll be very active at night, so it may lead to insomnia. So the second dose must be early evening. Always with meals, which was mentioned in 62.9, and we already know weighing yourself. The crucial part here is this one. Can they stop taking the steroids for whatever reason?
No.
No, in fact, I saw it on the list earlier on the table listing the causes of acute adrenal insufficiency. It was the abrupt cessation of corticosteroid therapy. However, there will be instances when these patients will have to stop it. So compare this to the sick day rules in diabetes, which is used to prevent DKA and HHS. Is it similar?
Yes.
Same idea. So you can't, just like you can't stop taking insulin, you can't stop checking your blood sugar. Same thing here. You can't stop the medication, so you can't skip them. If, however, it's impossible to take them because they're pills, and then your illness is maybe the flu, or it could be the GI flu. You have severe nausea, vomiting, diarrhea. So you can't take anything by mouth. So in that case, the patient will have to either give themselves an IM dose, or if they can't, or they don't know how to, or they don't have the means, then go to either the doctor or to the emergency department. So under no circumstance must they stop the medication, okay? Especially for 24 to 36 hours. Any questions? All right, let's take a break. I only have a few more to go after tonight. Come back at 8:05.
Okay. Thank you.
Professor?
Hyperaldosteronism, by the term itself, the only problem here is this patient has too much aldosterone. This is called Cushing Syndrome. It's not very common. I've only seen this once in a real person. And that person, since it was a quite rare instance, he was textbook. He was a male patient in his 30s. He had Cushing Syndrome, and he was literally a textbook patient. So his main problem is hypertension. So, and this patient literally had the symptoms of severe hypertension, which are the headache, the dizziness, the blurred vision, the nuchal pain, etc. Okay, the sweating, the nausea, a textbook patient. So the problem here is the patient has either primary aldosteronism, which is an adrenal problem, again in adenoma. Okay, adenoma again on the adrenal gland. But unlike the next one, which is pheochromocytoma, this one only affects the aldosterone level. So it doesn't affect unlike Cushing's also, wherein it affects the other hormone. This one only the aldosterone. Okay, so this adenoma is simply the one secreting a large amount of aldosterone. So all the problems result from high aldosterone, which is, again, will increase blood volume, will increase sodium levels, and therefore drop potassium levels. The patient, of course, will have consequences related to the hypertension. Okay, so the patient could have a hemorrhagic stroke or even a heart attack. And to some extent, if the blood pressure is not managed, then that will increase heart workload over time and cause heart failure. The hypertension also can lead to kidney damage. So it's not unheard of if these patients end up in dialysis. As already said, these patients present with manifestations of elevated blood pressure. So if you remember in chapter 36, hypertension has no symptoms, correct? Only until their blood pressure is really high. And this patient's blood pressure is in the 200s. This is not ordinary hypertension. Okay, so their blood pressure hovers around 180 or higher. They can reach in the 200s. So they will be having a cocktail here of blood pressure medications. The treatment, of course, is the removal of that. Until then, you just need to keep the patient alive through blood pressure medications and also through, other medications like spironolactone, for instance, because we have hypokalemia here. As with spironolactone, you hit 2 words, you have a diuretic, which will correct the potassium and sodium levels. So since surgery, our end goal, like I already said, you support the patient until the day of surgery. So the medications are symptomatic. You give blood pressure medications and potassium sparing diuretics. If just like in the treatment for Cushing's disease, since we're removing the adenoma here, which will also mean removing the adrenal gland, if we remove both, then the patient end up with less likely. Usually, consists only on the gland. So the patient will end up with a unilateral adrenalectomy, or again, for that reason, they will be on steroid replacements, both glucocorticoid and mineralocorticoid replacements for about 2 years. Otherwise, if you know already, if we remove both, then it'll be lifelong and they develop Addison's disease. And that's it. There's nothing else to talk about with syndrome. So mainly blood pressure, severely high blood pressure. So complications, namely stroke, heart attack, any injury. The last one is pseudochromocytoma. I'm sorry?
You're breaking a lot. I can barely hear you.
Okay.
My computer.
All right. I'm sure the video should be okay though, because I listened to it. It doesn't have the. But which part did you miss?
No, it's okay. Just letting you know. I'll catch up with the video.
You're better now, Professor. We can hear you clearer.
All right. So pheochromocytoma, this is another tumor. So pheochromocytoma is a tumor. This time it's only growing on the medulla now. So unlike what we had in Cushing's, wherein we were talking about the cortex, which is affecting the hormones, namely the aldosterone and the cortisol. This one, the tumor is growing in the medulla. Medulla is the part responsible for your epinephrine and norepinephrine. That's the part of the adrenal glands producing those catecholamines. Although they are usually benign, regardless though, they still cause a really high release of epinephrine and norepinephrine. So what are the 2 effects of these catecholamines when they are released?
Fight or flight response.
All right, so you're looking at a really jittery patient. So you have a really high heart rate here. You have vasoconstriction all the time. And of course, that will be very stressful on the heart, right? So in the same way, the patient will have the same high blood pressure as seen in Cushing syndrome. On top of that, though, is the really high heart rate that accompanies it. So here are your problems. Hypertension, which can have the attacks will raise which okay. So manifestations of the severe hypertension are these again. Okay. Because having an emergency or a life-threatening situation, because really that's what you're feeling, because these are your emergency hormones, right? So it's like you're always nervous and afraid of something. Okay, so you plus the palpitations don't help. Of course, this is a sympathetic response, so therefore what will happen to your GI function? Will you have normal peristalsis?
No, you're gonna have it active.
Okay, so well, actually you'll have nausea, vomiting, because remember in an emergency, it actually inhibits or affects peristalsis. Okay, however, at the time, it will cause the same effects on your cardiovascular system. Okay, the heart will workload, of course, will be increased. Unlike the other conditions, like in Cushing syndrome, the adenoma here is big. It really, I mean, it's really big. You will have a palpable mass here. Area, or sometimes it can also be palpable over the abdomen. One thing you do not do is touch that tumor. Right, so the tumor again grows quite big, so it can cause abdominal distension. Never touch that or palpate the tumor, because it will trigger a release of a large amount of catecholamines, which can probably cause a hemorrhagic stroke. So drugs are related to suppressing the hormones and the symptoms that occur with it. So we have antidepressants, because again, the patient has really this nervousness feeling all the time. You avoid other conditions that will make the hypertension worse, like tyramine. Okay, tyramine are basal you know, have you done this in psych, or are you taking psych right now?
Yeah, the time, I mean, with the aged cheese or wine or processed meat.
Okay, very good. So just like Cushing syndrome, how do we cure this? Surgery again. But until surgery is done, you just manage the patient's symptoms. Hypertension, again, is your #1 problem here, which can also lead to, again, heart failure or even kidney failure. I already said this, do not palpate that mass because it can be seen on the abdomen. In fact, they grow so large that it will actually impair GI function. So it can cause a little bit of bowel, right? So they can have constipation here because the mass, the tumor is quite big.
Does it cause tumor lysis? Like
no, not like because this patient is
of
not,
electrolytes in the body.
no, because they're not treated with, this tumor is not treated with chemotherapy. You just simply remove it. Surgery is the permanent cure. And that's it. I really don't have much about pheochromocytoma. Any questions?